Can you describe a time when you had to care for a deteriorating patient and how you managed the situation?
While working on a busy 30-bed surgical ward, I was assigned to a post-operative patient for 3 days following a major abdominal resection. During my mid-morning rounds, I observed that the patient appeared unusually pale and was struggling to complete sentences. I immediately initiated a primary assessment using the ABCDE framework. I found his respiratory rate had spiked to 28 breaths per minute, and his oxygen saturations had dropped to 89% on room air. Recognizing the clinical urgency, I stayed with the patient to provide reassurance while simultaneously using the emergency call system to summon assistance. I administered high-flow oxygen via a non-rebreather mask as per standing protocols and performed a full set of vital signs, which revealed a tachycardia of 120 BPM and a significant drop in blood pressure. I used the ISBAR communication tool to provide a concise, structured handover to the surgical registrar and the clinical nurse manager, emphasizing the National Early Warning Score of 8. I facilitated immediate arterial blood gas sampling and ensured intravenous access was patent for fluid resuscitation. By maintaining a calm environment and providing clear instructions to the healthcare assistant helping me, we stabilized the patient until he was transferred to the high-dependency unit. This experience reinforced the critical importance of early recognition and structured communication in preventing adverse outcomes. It also highlighted the necessity of adhering to national clinical guidelines to ensure patient safety. The challenge lay in managing a high-stress clinical emergency while the ward was at full capacity, but by prioritizing the highest risk and delegating effectively, I ensured the patient received life-saving intervention without delay. This experience has made me more vigilant in monitoring subtle changes in post-operative observations to prevent similar escalations in the future.
Tell us about a situation where you had to advocate for a patient's needs.
I once cared for an elderly patient with limited English proficiency who was being prepared for a complex orthopedic procedure. During the preoperative check, it became clear that although a consent form had been signed, the patient was distressed and could not explain the risks or the nature of the surgery. The surgical team was under significant pressure to maintain the theater schedule and felt the signed form was sufficient to proceed. However, I recognized that the patient's right to informed consent and dignity was being compromised due to a language barrier. I took the initiative to pause the process, explaining to the surgical lead that the patient did not have a full understanding of the intervention. I contacted the hospital's authorized translation service to facilitate a three-way conversation. During this call, the patient was able to ask specific questions about his post-operative mobility and pain management, which had been the source of his anxiety. Once he felt fully informed, he reaffirmed his consent with confidence. This delay of 30 minutes ensured the patient's autonomy was respected and improved his overall compliance with a post-operative rehabilitation plan. It demonstrated that being an advocate sometimes requires the courage to challenge timelines to ensure ethical, person-centered care. The main challenge was standing my ground against a senior surgical team in a time-sensitive environment, but my commitment to the professional code of conduct and patient rights took precedence. I learned that clear communication and utilizing available resources like translation services are vital in protecting vulnerable patients from being overlooked in a fast-paced hospital setting. This outcome not only protected the patient but also mitigated the legal and ethical risks for the hospital regarding valid consent.
Describe a time you dealt with a conflict within the multidisciplinary team.
During a multidisciplinary discharge planning meeting, a disagreement arose between the physiotherapy team and the social work department regarding a patient's readiness to return home. The physiotherapist felt the patient was at a high risk, while the social worker was under pressure to free up the bed due to acute admission demands. As the primary nurse, I occupied a central role in this conflict. I realized that the tension was stemming from a lack of shared data regarding the patient home environment. To resolve this, I presented my documented observations of the patient's fluctuating cognitive status during night shifts, which had not been previously considered. I proposed a compromise, a formal home environment assessment to be conducted within 24 hours while keeping the patient on the ward for one additional day of intensive balance training. By focusing on objective clinical evidence and the shared goal of patient safety, I helped the team move away from professional friction toward a collaborative solution. The patient eventually discharged safely with a tailored package of care, preventing a likely readmission. This taught me that effective conflict resolution in a hospital setting relies on bringing all parties back to evidence-based practice and the patient's welfare. The challenge was managing the conflicting professional priorities of two different departments while ensuring the patient did not feel the tension of the team. I achieved this by remaining neutral and advocating for a safety-first approach. This experience improved my ability to navigate complex interprofessional dynamics and emphasized the importance of comprehensive documentation to support clinical arguments during disputes. Following this, I made it a priority to ensure all MDT members had access to my nursing notes prior to meetings to ensure everyone was working from the same information.
Give an example of how you have ensured medication safety during a high-pressure shift.
On a particularly short staff night shift, I was responsible for a double-sided medical ward with several high-dependency patients requiring complex intravenous infusions. I recognized that the increased workload and frequent interruptions created a significant risk for medication errors. To mitigate this, I implemented a no-interruption zone during the drug round, utilizing a red tabard to signal to colleagues and families that I was performing critical checks. When preparing a high-alert potassium infusion for a patient with severe electrolyte imbalance, I encountered a distraction from an alarm elsewhere. Instead of continuing, I stopped, secured the medication, and restarted my double-check process from the beginning with another registered nurse. I adhered strictly to the 6 rights of medication administration and verified the patient's allergy status and identity against their wristband and electronic record. By refusing to rush despite the environmental pressure, I ensured that every medication was administered accurately and safely. This disciplined approach not only protected the patients, but also set a standard for the junior staff on duty, highlighting that clinical safety must always take precedence over speed. The primary challenge was balancing the urgent needs of the ward with the meticulous nature of medication safety, which I handled by creating a physical and mental boundary for the task at hand. I also briefed the healthcare assistants to manage minor patient requests during the round to minimize my distractions. This resulted in a zero-error shift and maintained the integrity of our clinical governance protocols. I now advocate for these safe zone practices during every shift to ensure the ward maintains a culture of safety regardless of staffing levels or patient acuity.
Tell us about a time you had to manage multiple competing priorities.
At the start of a day shift, I was assigned 6 patients. One was being prepared for an urgent discharge, another was returning from the operating theater, and the third had just reported sudden, sharp chest pain. I immediately applied a clinical triage approach to my workload. My first priority was the patient with chest pain, as this represented a potential life-threatening emergency. I initiated an ECG and alerted the medical team within 5 minutes. Once that patient was stabilized and under the care of the doctor, I turned my attention to the post-operative return. I ensured the bed space was ready with appropriate monitoring equipment and received a structured handover from the recovery nurse, then delegated the initial frequent vital signs to a competent healthcare assistant while I performed the first clinical assessment. Finally, I addressed the discharged patient, providing their education and prescriptions once the clinical emergencies were managed. Throughout this period, I maintained constant communication with a clinical nurse manager to provide updates on my progress. This systematic approach allowed me to maintain a high standard of care for all patients by addressing the highest clinical risks first while ensuring the flow of the ward remained functional. The challenge was the cognitive load of switching between an emergency, a post-op recovery, and administrative discharge tasks. I successfully managed this by using a written task list and clearly delegating non-clinical tasks to support staff. As a result, the medical emergency was handled swiftly, the post-op patient was safely admitted, and the discharge was completed within the hospital's target timeframe. This experience solidified my ability to remain calm and methodical under extreme pressure, a skill I bring to every shift at the university hospital.
Describe a situation where you implemented infection control measures effectively.
While managing a bay in a medical ward, I identified that a patient admitted with a chest infection had developed sudden-onset diarrhea. Suspecting a potential healthcare-associated infection like Clostridium difficile, I immediately initiated source control. I moved the patient to a single isolation room with in-suite facilities within 20 minutes of the symptoms appearing. I ensured that prominent signage was placed on the door and that a dedicated personal protective equipment station was established outside the room. I briefed the entire multidisciplinary team and the cleaning staff on the requirement for enteric precautions, including the use of soap and water rather than alcohol gel for hand hygiene. Furthermore, I took the time to educate the patient's family on these measures to prevent cross-contamination. By acting decisively before laboratory confirmation was received, I prevented the spread of the pathogen to the other vulnerable patients in the bay. This proactive adherence to HICA standards and local HSE protocols demonstrated my commitment to maintaining a safe environment and minimizing the duration of the outbreak on the ward. The challenge was finding an available isolation room on a full ward, but I worked with the site manager to reprioritize bed allocations based on infection risk. My actions were later commended during a clinical audit as an example of best practice in early containment. This reinforced the importance of clinical suspicion and immediate action in infection prevention. I continue to mentor junior staff on the necessity of prioritizing source control at the first sign of symptoms to protect the wider hospital population.
Tell us about a time you mentored a student or a junior colleague.
I was assigned as a preceptor for a final-year nursing student during their 6-week clinical placement on a busy surgical unit. I recognized that the student was technically proficient but lacked confidence when communicating with the surgical consultants during grand rounds. To support their development, I first observed their current interaction style and then held a private feedback session where we discussed the ISBAR framework. I set a specific goal for the following week. The student would lead the handover for 2 of our shared patients. Before the doctors arrived, we practiced the summary together, focusing on highlighting the most pertinent clinical facts. During the round, I stood beside the student to provide a supportive presence, but allowed them to speak. When they hesitated on a specific lab result, I prompted them gently rather than taking over. Over the course of the placement, I saw a significant transformation in their clinical leadership and communication skills. By providing a structured environment for growth and constructive real-time feedback, I helped prepare them for the transition to a registered nurse role, which is a core responsibility outlined in the HSE job specification. The challenge was balancing my own heavy workload with the time required for effective teaching, but I integrated the student into my daily tasks so that the teaching was experiential rather than purely theoretical. The result was a student who passed their final assessment with high marks and went on to be a confident, capable staff nurse. This experience strengthened my own communication skills and my ability to identify the unique learning needs of different team members.
Describe a time you had to deal with a difficult or aggressive family member.
I once encountered a family member who was shouting at the nursing station because they felt their father's pain was not being adequately managed. I recognized that the individual's aggression was likely a manifestation of fear and frustration. I immediately stepped out from behind the desk to meet them at eye level, using a calm and non-confrontational tone. I invited them into a private quiet room to allow them to express their concerns without an audience, which helped to de-escalate the immediate tension. I listened actively without interrupting, acknowledging their feelings by saying, "I can see you are very distressed about your father's comfort." Once they had calmed down, I explained the current pain management plan, showed them the medication administration record, and explained why we were following a specific titration schedule. I then brought the patient's doctor in to discuss a potential review of the analgesia. By addressing the person with empathy and providing clear, transparent information, I was able to rebuild trust. The family member apologized for their outburst, and we established a more productive communication channel for the remainder of the patient's stay. The challenge was maintaining my own composure while being verbally confronted in a public area, but I focused on the de-escalation training I had received. This resulted in a safer environment for the staff and a better outcome for the patient, as the family became partners in care rather than obstacles. I now utilize these active listening techniques early in my interactions with families to prevent frustrations from reaching a boiling point.
Give an example of how you have used evidence-based practice to improve patient care.
In my previous role, I noticed an increase in the incidence of pressure ulcers among long-stay patients on our medical ward. I decided to lead a small clinical audit to identify the gaps in our current practice. The data revealed that while at-risk patients were identified, the frequency of repositioning was not being consistently documented or performed during busy periods. I researched the latest international guidelines on pressure area care and presented the findings to my clinical nurse manager. With her approval, I introduced a skin bundle checklist and a simplified repositioning clock at each bedside. I also organized brief huddle sessions for the healthcare assistants to emphasize the importance of early skin assessment. Over the following 3 months, our ward saw a 40% reduction in hospital-acquired pressure injuries. This project demonstrated my ability to relate nursing research directly to clinical practice and showed how small, evidence-based changes can have a significant impact on patient outcomes and the quality of the service provided. The challenge was changing the established culture of the ward and ensuring that documentation was seen as an essential part of care rather than a burden. I overcame this by showing the staff the tangible improvements in patient comfort and skin integrity. This initiative not only improved patient outcomes but also reduced the financial and resource burden on the ward associated with treating complex wounds. I am committed to bringing this same research-oriented mindset to the medical and surgical wards at the University Hospital to ensure we are always following the highest clinical standards.
Tell us about a time you had to adapt to a major change at work.
When my hospital transitioned from paper-based records to a comprehensive electronic health record (EHR) system, it represented a significant shift in our daily workflow. Many staff members were anxious about the learning curve and the potential for the technology to distract from direct patient care. I chose to embrace the change early by volunteering to be a super user for my department. I attended advanced training sessions 2 weeks prior to the launch so that I could support my colleagues during the transition. On the day of Go Live, I remained flexible, extending my shift to help the night staff navigate the new system. I found that while the initial documentation took longer, the ability to access real-time lab results and clear medication orders actually improved our clinical decision-making. By maintaining a positive attitude and acting as a peer support resource, I helped my team overcome their initial resistance. The challenge was managing the technical glitches that occurred during the first few days while still providing high-quality care, but my preparation allowed me to troubleshoot quickly. This experience proved my adaptability and my willingness to develop the IT skills necessary for modern nursing as required by the HSE. The result was a successful rollout with minimal disruption to patient care and a team that eventually found the electronic system more efficient than the old paper records. I am eager to apply my technical proficiency and positive attitude toward future system upgrades or policy changes at the University Hospital.
Describe a situation where you had to make a difficult decision with limited information.
During a night shift, a patient became acutely confused and tried to leave the ward, posing an immediate safety risk. The patient had no prior history of dementia or delirium, and the on-call doctor was tied up in an emergency in another department. I had to decide whether to involve security or use restrictive measures to keep the patient safe. I quickly reviewed the patient's most recent vitals and medication list, noting they had started a new antibiotic that evening. Suspecting a drug reaction or a rapid onset of sepsis, I decided to focus on clinical de-escalation rather than physical restraint. I assigned a healthcare assistant to sit with the patient in a quiet area while I performed a bladder scan and a fingerprint glucose test to rule out common causes of delirium. I also contacted the surgical registrar again, providing a more urgent SBAR report. My decision to treat the behavior as a medical symptom rather than a security issue led to the early diagnosis of a urinary tract infection and prevented a potential fall or elopement. The challenge was the ambiguity of the patient's sudden behavioral change, but by applying a systematic clinical approach, I arrived at the correct intervention. This taught me the value of using clinical intuition and systematic assessment, even when time and resources are limited. The patient was treated successfully and returned to his baseline cognitive function within 48 hours. This experience reinforced the importance of looking for the underlying medical cause of behavioral symptoms to ensure the most effective and least restrictive care.
Tell us about a time you went above and beyond for a patient.
I was caring for a terminally ill patient who expressed a deep wish to see his pet dog one last time. Due to strict hospital hygiene policies, this was not standard practice. However, I recognized the profound impact this would have on the patient's psychological well-being and end-of-life experience. I consulted with the infection control team and the ward manager to see if an exception could be made. We developed a plan where the dog could be brought to a secluded outdoor garden area of the hospital, and we would transport the patient there in a wheelchair with portable oxygen and monitoring. I coordinated the timing with the family and ensured the patient was medicated for pain prior to the move. Seeing the patient's joy and peace during that meeting was incredibly rewarding. While it required extra coordination and time during a busy shift, it fulfilled the core nursing value of providing holistic, person-centered care. The challenge was ensuring that all safety and infection control protocols were strictly followed while facilitating this non-traditional request. I handled this by documenting every step and getting formal approval from the relevant departments. This act of compassion had a lasting positive impact on the family's bereavement process and demonstrated that nursing extends beyond clinical tasks to addressing the human spirit. This experience cemented my belief that advocacy and empathy are as critical as clinical skills in providing high-quality nursing care. I strive to bring this level of dedication to every patient I care for.
Describe a time you identified a risk to patient safety and took action.
While preparing to transfer a patient to the radiology department for an MRI, I noticed that the transfer documentation did not mention the patient had a permanent pacemaker. When I checked the patient's chest, I confirmed the presence of the device. I immediately halted the transfer. I knew that taking a patient with a non-MRI compatible pacemaker into the magnetic field could be fatal. I contacted the cardiology department to verify the specific model and checked the radiology department's safety protocol. It turned out the pacemaker was an older, non-compatible model. I updated the medical team and the radiology staff, and the scan was canceled in favor of a CT scan. I then completed an incident report using the National Incident Management System, not to blame my colleagues, but to highlight a gap in our pre-procedure screening process. This led to a revision of the surgical pre-assessment checklist to include a mandatory physical check for implanted devices. My vigilance prevented a catastrophic error and contributed to the overall clinical governance of the hospital. The challenge was the pressure to maintain the radiology schedule, but I prioritized patient safety over hospital throughput. This result was a safer systemic process for all future patients undergoing scans. I learned that never assuming the documentation is complete is a vital safeguard in clinical practice. This experience has made me a more meticulous auditor of patient safety checklists, and I now take an active role in briefing my team on the importance of stopping the line whenever a safety concern is identified.
Give an example of how you have contributed to a positive team environment.
On our ward, morale had become low due to a period of high staff turnover and increased patient acuity. I realized that the team was missing a sense of appreciation and connection. I proposed the introduction of a safety huddle at the start of every shift, not just to discuss clinical risks, but to end with a positive shout-out where staff could recognize a colleague for a job well done. I also initiated a well-being board in the break room where we shared useful resources and small wins. I made a conscious effort to check in with my colleagues during the shift, especially the newer staff, asking, "How are you doing?" and offering a 5-minute break if they looked overwhelmed. By modeling supportive behavior and encouraging open communication, I helped shift the culture toward one of mutual respect and resilience. Over time, staff reported feeling more supported, and our teamwork during emergencies became much more cohesive. The challenge was overcoming the initial cynicism toward these initiatives, but I persisted by being the first to give positive feedback every day. This demonstrated my leadership potential and my commitment to building the professional relationships necessary for a high-functioning healthcare environment. A positive team environment directly impacts patient safety. The staff feel more comfortable speaking up about concerns. I am committed to fostering this same culture of support and appreciation at the University Hospital, recognizing that the strength of the nursing team is our greatest asset in providing excellent care.
Describe a time you had to explain a complex medical condition to a patient or family.
I was caring for a patient newly diagnosed with heart failure who was overwhelmed by the sudden dietary restrictions and medication changes. The doctor had provided a technical explanation, but the patient was still confused and anxious about going home. I sat down with the patient and his wife, using a simple diagram of a heart as a pump to explain how the fluid was backing up in his lungs. I avoided medical jargon, instead using the analogy of a sponge to explain how his water tablets, diuretics, worked. I provided written materials in a clear, large print format and used the teach-back method, asking the patient to explain to me, in his own words, how he would monitor his way to home. By breaking the information down into manageable pieces and ensuring he had a practical plan, I reduced his anxiety and improved his readiness for discharge. The challenge was the patient's low health literacy. but by using visual aids and relatable analogies, I bridged the gap in understanding. This effective communication ensured that the patient felt empowered to manage his health, which is a key component of the staff nurse role in promoting independence. The result was a patient who left the hospital feeling confident rather than afraid, which significantly reduces the risk of noncompliance and readmission. I consistently apply these health literacy strategies in my practice to ensure all patients, regardless of their background, have the information they need to recover safely at home.
Tell us about a situation where you had to work under minimal supervision.
During a weekend shift, I was the most senior nurse on a surgical ward when the clinical nurse manager was called away to an emergency meeting. Shortly after, we received an unexpected blue light admission from the emergency department while another patient started showing signs of a post-operative bleed. I had to step into a leadership role immediately. I delegated the admission assessment to a junior nurse, giving her clear parameters on what to report back to me. I then took direct charge of the patient with the bleed, initiating vital signs, increasing fluids, and paged the surgical registrar using the SBAR tool. I maintained a calm presence, ensuring that the other patients on the ward still received their scheduled medications and care by reorganizing the healthcare assistance tasks. I stayed in constant contact with the bedside nurses to ensure they felt supported. By the time the manager returned, both situations were under control and documented correctly. This experience proved my ability to take accountability, manage a unit, and provide clinical leadership during challenging circumstances as outlined in the job specification. The challenge was the sudden increase in acuity without senior support on the floor, but my previous experience in emergency scenarios allowed me to triage effectively. This resulted in the surgical patient being stabilized for theater and the new admission being processed without delay. It confirmed my readiness to assume responsibility for a unit in the absence of a manager, ensuring continuity of care and safety for all patients.
Give an example of a time you failed or made a mistake and how you handled it.
Early in my career, I realized 2 hours into my shift that I had forgotten to document a wound assessment for a patient who had since been discharged. I felt a great deal of professional guilt, as I knew that accurate record-keeping is a legal and ethical requirement. Rather than ignoring the omission, I immediately informed my clinical nurse manager. We discussed the situation, and I followed the local policy for making a retrospective entry in the patient's notes, clearly marking it as such and ensuring the information was as accurate as possible based on my memory and the handover notes. I then reflected on why the mistake happened and realized I was trying to do too many tasks at once without using a structured to-do list. From that day on, I adopted a systematic planner for my shift to ensure every clinical task and its documentation were completed in real time. This experience taught me that integrity means owning your mistakes and using them as a learning opportunity to improve your future practice. The challenge was overcoming the fear of admitting a mistake to a supervisor, but the professional growth that followed was invaluable. This incident made me a champion for thorough documentation among my peers, and I now use this story to teach students about the importance of accountability and the culture of safety over a culture of blame. My subsequent documentation audits have been flawless, demonstrating a sustained change in my professional practice.
Describe how you stay up to date with your professional development.
I am deeply committed to the principle of lifelong learning, which I believe is essential for providing high-quality care. In the last year, I have completed several HSE modules, including Advanced Cardiac Life Support and the National Open Disclosure Program. I also regularly read the nursing standard and attend our hospital's monthly journal club, where we critique recent research papers on surgical nursing. For example, after reading a study on the benefits of early mobilization post-surgery, I work with our ward's physiotherapist to implement a more proactive up and about protocol for our elective orthopedic patients. I maintain a professional portfolio where I record my reflections on challenging clinical cases, which helps me identify areas where I need further training. By staying curious and engaged with the latest evidence, I ensure that my practice remains safe, effective, and aligned with the current NMBI standards. The challenge is finding the time for study in a busy professional life, but I dedicate 2 hours a week to self-directed learning as part of my professional responsibility. This resulted in me being the designated resource person on my ward for new clinical guidelines. I believe this commitment to development will allow me to contribute to the teaching hospital environment at the University Hospital, supporting both my own growth and the education of others. I am eager to participate in the specific training opportunities mentioned in the job spec to further specialize in medical and surgical care.
Tell us about a time you had to handle a high-stress situation involving several people.
I was involved in a code blue cardiac arrest in the hospital cafeteria where there were many members of the public present. The situation was chaotic and high stress. I immediately took the lead, identifying myself as a nurse and directing one bystander to call the emergency number and another to fetch the nearest AED. I began chest compressions while instructing a colleague who had arrived to manage the airway. I was conscious of the crowd, so I asked 2 security guards to create a privacy screen using chairs and to move people away from the scene. When the arrest team arrived, I provided a clear SBAR handover, including the duration of CPR and the number of shocks delivered. My ability to remain composed and provide clear, authoritative direction prevented panic and ensured the patient received the best possible chance of survival. This situation demonstrated my resilience, my ability to lead in a crisis, and my commitment to public safety even outside the clinical ward environment. The challenge was managing the emotional reactions of the public while performing life-saving treatment, but my training allowed me to compartmentalize and focus on the patient. The result was a successful resuscitation and the patient being transferred to the coronary care unit. This experience proved that I can maintain my professional standards and leadership skills under the most extreme and public pressure, ensuring that I am a reliable and calm presence in any emergency that might occur at the university hospital.
Why do you want to work for the university hospital specifically?
I have followed the development of the university hospital as a Level 3 teaching hospital with great interest, particularly its strong academic partnerships with UCC and SITU. I am drawn to your hospital's mission of teaching, understanding, and healing, which aligns perfectly with my own professional values of continuous learning and person-centered care. I am particularly impressed by the hospital's bidirectional flow with Model 4 centers like Cork University Hospital, which indicates a sophisticated and integrated approach to patient management in the Southeast region. Having worked in medical surgical settings previously, I'm eager to bring my skills in ABCDE assessment and clinical governance to your team. I am looking for a role where I can contribute to the high standards of infection control and patient safety for which TIPUH is known. I am confident that my experience in managing complex caseloads and my dedication to the HSE values of care, compassion, trust, and learning make me an excellent fit for your surgical and medical wards. The challenge for any nurse at TIPUH is the wide catchment area and high patient throughput, but I'm energized by the opportunity to provide quality care to the local population of 160,000. My goal is to become a long-term member of your nursing staff, eventually contributing to your teaching and research initiatives while delivering excellent frontline care. I am excited about the possibility of joining such a forward-thinking and community-focused healthcare institution,